Hi, my name is Julie Lunsford. The following presentation will address the Stakeholder Education Plan for project implementation. Emergency department overcrowding is a result of multiple variables. Access to care is a common contributing factor throughout our communities in our nation. There is an existing shortage of primary care providers, thus individuals utilize the emergency department for non-emergent health issues. Unfortunately, there is no quick fix to redirect patients to the appropriate care facilities. Uninsured and indigent patients frequently present to the ED due to lack of funds to pay a primary care provider. The cost of emergency care is then shifted to the paying or insured patients in order for hospitals to survive financially. The healthcare reform has exacerbated emergency department census. Due to this ripple effect, emergency departments need to reevaluate their process of patient flow. The mismatch of patient medical needs, available resources, and emergency department crowding is what prompted the innovation of triage redesign. Rapid triage would assist in prioritizing patients to expedite provider treatment, especially for the more critical cases. The following presentation will identify the stakeholder groups involved in their role in the project implementation. A theoretical foundation to guide the innovation will be introduced. In order for any new innovation to be successful, you must first identify if there is an existing problem, such as traditional triage versus rapid triage. Once this has been accomplished, it is necessary to make an observation of who your primary stakeholders are and to gain their buy-in of the innovative change. The triage transformation will begin with the interdepartmental shareholders. They are the foundation for successful change, especially since they will be directly affected regarding task reallocation. The emergency department providers, physicians, nurse practitioners, and physician assistants are yearning to implement the change, especially if it decreases door-to-provider times. The emergency department director is somewhat old school and does not readily adapt to change. Her buy-in will be accomplished when she recognizes staff job satisfaction, improved patient safety, long-term cost savings, and improved patient satisfaction. The RN staff have expressed their excitement to redesign triage. Their buy-in is critical since they are the individuals performing the task. The licensed vocational nurses have been involved with the transformation as well. 4 of the 6 LVNs will have their RN degree at the time of implementation. The remaining 2 LVNs have expressed interest in their job reallocation to the emergency department waiting room. The RNs will assist in revision of the triage process. Research of JCO triage standards will be reviewed prior to triage template redesign. The IT department will be presented with the triage template changes and redesign the computer template. IT involvement will be somewhat limited. A time study will be performed to determine the actual costs of inappropriate treatment room assignments. The non-medical meet and greet staff will continue their role of escorting patients to the appropriate treatment room as assigned. Our meet and greet staff provide patients with an extra touch of compassion, thus improving patient satisfaction. The Quality Assurance Committee will continue to monitor any adverse or sentinel events and potential litigation cases, as they currently do. Value-added patient care is our central goal for this implementation. That will be the opening line when presenting to the next group of stakeholders, administration. It will be critical to have a simple yet informative outline of the innovation. Items to be included will be cost of an all-RN staff in the treatment area, save costs for appropriate treatment room assignments, decreased length of stay, and decreased door-to-provider time. A key selling point will be improved patient satisfaction. PRMC administration is not built on the Newtonian principle of mechanistic functioning, compartmentalization, and vertical control. Porter, O'Grady, and Malik, 2011. Administration had more of a horizontal approach to change. As the final stakeholder group, they express the importance to work together as a team versus compartmentalizing each specific department. The Chief Financial Officer will be the key player, and the cost analysis will be meticulously prepared for her buy-in. The educational component for administration will be value-added service. Sequential process, things done one thing at a time, decreases value. The innovation will promote parallel process, several things done at once, to increase the value. An example is a pull-till-full policy in bedside triage. Stakeholders will need to value and support the new initiative, viewing it as an opportunity versus a threat. Administration will receive continuous feedback as the implementation unfolds. Their agreement to the upfront implementation costs in order to recoup costs and revenues in the long run will assist in project facilitation. In any innovation, it is important to have an educational plan. This will assist in determining at what level each of the stakeholders are currently in. The Knowles Adult Learning Theory is a helpful foundation and consists of 6 principles. Most adults are self-directed and internally motivated. It is important that a presentation is short and informative, as well as opening the meeting to questions. A simple response to questions prevents confusion and delays. Feedback, both positive and negative, reviewing current and future goals, with the team will engage participation and enthusiasm for success. We have lifetime experiences to draw from our past lives. How we have dealt with those experiences can provide the knowledge to problem solve, reflect, and improve our knowledge base. Being goal-oriented provides adults the opportunity to self-motivate and explore different avenues to reach a common outcome. As adult learners, we seek to find the relevancy of why we do things, the purpose of our actions, and how our behavior will apply to future events. Since adults are practical, they should be given the opportunity of trial and error to reach a positive outcome. Simple observation restricts our ability to grow and learn, thus making us stagnant. And lastly, we all embellish the respect of others. In order to gain respect, we must show respect. This is demonstrated by being open to new ideas, acknowledging individual accomplishments and giving them credit, listening, and the exchange of constructive feedback. The different levels of stakeholders and their roles in the project implementation have been reviewed, as well as the educational theory. The following dialogue is a specific plan for creating a favorable organizational climate to implement the scholarly project. A model for evidence-based practice will be utilized as a guide to implement the innovation. The evidence-based model is derived from theoretical and research literature related to evidence-based practice, research utilization, and change theory. Ross, Worm, and Larrabee, 1999. The model will assist in guiding the innovation through the entire process of changing to evidence-based practice. The model begins with the assessment of the need for change and ends with the integration of an evidence-based protocol. The initial step is to assess the need for change in practice, triage redesign. Triage standardization is the identified problem. This stage would include identifying stakeholders, collection of internal data about current practice, and comparing internal data with external data. Step 2 is linking problem interventions and outcome. Triage redesign would decrease door-to-provider time, decrease length of stay, and improve patient satisfaction. Using standardized classification systems and language, identifying potential interventions and activities, and selecting outcome indicators complete this stage. Synthesizing the best evidence is step 3. In order to compare the different triage guidelines, a search of research literature related to the major variables will be conducted. The evidence will be critiqued, weighed, and synthesized to determine what is our best fit. This stage will be finalized assessing the feasibility, benefits, and risks of the innovation. The design phase evaluates practice change, standardized triage versus streamlined triage. During this phase, we would define proposed change, identify needed resources, plan the implementation process, and define outcomes. Stage 5 is to implement and evaluate the change in practice, triage redesign. A pilot study demonstration would assist in evaluating the process and outcomes. A decision would be made to adapt, adopt, or reject the practice change. The final stage is to integrate and maintain the change in practice, discard the lengthy triage practice, and incorporate triage redesign. Communicating the recommended change to stakeholders will be critical. An in-service to educate the staff on change practice will be presented. Once the staff completed the on-the-job in-service, the innovation will be integrated into standards of practice. The process and outcomes will be monitored for quality assurance, and the 6 stages provide a foundation to guide the implementation for innovative change. Though individual stages are presented, there may be times of overlap during the process change. In summary, emergency department overcrowding is a nationwide problem. Triage redesign is just one of the many avenues to improve emergency department efficiency. Your true stakeholders are on the front line next to you. We know what needs to be accomplished for value-added service, yet have to sell the innovation to administration, cost being a major factor. This class is providing the information to assist in improving my political and economic agility. Thank you.